So good morning, ladies and gentlemen, and warm welcome to Trendo 2022. And on the outset, I like to thank the organizers for organizing such a wonderful academic feast over the last 1.5 days, and it's going to be much more for the next one day. And let's go into the straight to our topic for today. It's about case-based discussion on hyperprolactinemia. So we are going to have four panelists here. I would request a panelist to come on stage, please. Dr. Sundaraman sir, Dr. Anandakumar Annamalai, Dr. Adeline Rina Asirvadam, and Dr. Senthil Raja. So I welcome the panelists again. Thanks for coming. Our discussion would be like this. We are going to have 4 case-based discussions, and it will be a discussion between the panelists, and there will be an educational point and subsequently on that. And if there is any questions, we are happy to take up those questions in the last few minutes of the presentation so that we can have a lively discussion furthermore. So I'm starting with the first case. This is a lady of 29 years who has come to endocrinology OPD with a history of galactorrhea over the last 1 year, and she's married and eager to conceive, and she had irregular cycles with amenorrhea over the last 1 year, 2 years, and had weight gain, and she's not on any other medication for her current illness. When we examined, she had dull face with dry skin and slow ankle reflex, no other hypercalcemic signs or any other signs, but she was having galactorrhea, had a clinically palpable goiter with a slightly high diastolic blood pressure and pulse around 66, and a cardiovascular system a little muffled heart sound. So I would like to ask the panelists, Dr. P.G. Sundaraman, so what is the mechanism for a galactorrhea in patients with hypothyroidism? Because this is very clinically a patient with hypothyroidism. So what is the mechanism of galactorrhea in patients with hypothyroidism?
Once again, I must thank the Trendo 2022 for giving me this opportunity. In fact, it's quite interesting that prolactin is a very primitive hormone. In fact, a small introduction about it. It was actually the molecule was isolated in non-humans by Oscar Riddle. And in fact, that was initially for the electrolytes, ion exchange, and for milk production. Now, prolactin is a very unique hormone in the sense that it is not only produced in the pituitary gland, but it's also produced from various tissues. In fact, the decidua also produces prolactin, the breast produces prolactin. And unlike the other pituitary hormones, the feedback mechanisms, the axis, is not full-fledged, and it is always under the inhibitory mode. And it has got a lot of functions, including immunological function. And if you find the major inhibitory hormones are the dopamine, the GABA, and the somatostatin, and which stimulates the prolactin secretion is the TRH. And also, it is being stimulated by oxytocin, VIP hormone, vasopressin, estrogen, norepinephrine. So, TRH in hypothyroidism is elevated because when there is a low secretion of T3 and T4, there is a feedback axis that stimulates the TRH production, and TRH, which is a stimulant of prolactin hormone, stimulates the prolactin secretion. So in turn, this prolactin gives rise to the signs and symptoms of hyperprolactinemia that causes galacturia. So that is the basic mechanism of the TRH causing elevated levels of prolactin.
Thank you, sir, for the uh, well explanation. As we further proceed into the investigation, this lady had a slightly high normal creatinine with prolactin in dilution of 122 nanogram per ml. It's important that we need to look up the reference range for that particular lab, because there are at least two different values, and even sometimes in molar values also they tend to give the values. And TSH is high, and as expected, the total T4 and free T4 were low. So I would like to ask Dr. Senthil Raja, so how does this prolactin causes an ovarian dysfunction, especially in this patient?
Yeah, good morning all. This prolactin is how it causes the reproductive dysfunction is mainly it inhibits kisspeptin neurons in the hypothalamus, so thereby GnRH pulsatile secretion will be less in patients with hyperprolactinemia. At the same time, it inhibits FSH and as well as LH secretion at the level of pituitary. Third thing is, at the level of ovulation, it inhibits folliculogenesis as well as it causes luteal phase defect. And in patients with pituitary adenoma, macroadenoma, because of mass effect also, the gonadotroph will be suppressed. So these are the mechanisms where it can cause infertility.
Thank you, Dr. Senthil. And Dr. Anand, can you just mention how does the high prolactin, what is the line of management for this patient?
So as reiterated by my colleagues, so here the increased prolactin is because of the increased TRH. So the importance is we need to reduce the TRH. And how are we going to reduce the TRH is by treating the hypothyroidism. So we need to initiate levothyroxine for this patient, and by doing so, that would decrease the TRH and that would decrease the prolactin. So we would need to initiate levothyroxine for this patient as the line of management. The important issue obviously is to titrate as per the TSH, and that would result in a normalization of the prolactin.
Thank you, Dr. Anand. So the learning objectives
I
is
just
that
want to add one more line, because it's for the practical aspect of the obstetrician. Many times you find that the people add on dopamine agonists like bromocriptine. Now here it is not essential to add on the dopamine agonist along with the thyroxine. So many times they combine both thyroxine and bromocriptine. So that must be avoided, because sometimes it takes time for the prolactin to decrease. So that must be kept in mind.
Helen, would you like to add up any more information on this particular topic we are having? In terms of, you want to add on anything on subclinical hypothyroidism and a mild rise in prolactin?
The hyperprolactinemia in this case seems to be secondary to the overt hypothyroidism, as already mentioned, due to an increase in TRH. But subclinical hypothyroidism can present or can have hyperprolactinemia, but it's usually very mild. And many times it goes unnoticed because the borderline elevation of prolactin doesn't have a clinical impact. But having said that, even some case series are there to show that even treating subclinical hypothyroidism can bring down the prolactin. Now, just wanted to mention that the mild raised creatinine seen in this patient is also secondary to the overt hypothyroidism, possibly due to the low eGFR that happens because of hypothyroidism. So treating the hypothyroidism will be the bottom line for the anovulation and also for the raised creatinine in this case.
Yeah, thank you, Dr. Adler.
I'll just add one more, Felix.
Yes, sir.
So
Please.
the other important thing also is in terms of management, because many times, people get a scan without a need in this kind of a situation. And because of what has been discussed, because of the lactotroph hyperplasia, you would actually find that actually the pituitary is enlarged. And this must not be mistaken for a pituitary adenoma and wrongly sent for surgery. I think that is a very vital thing which needs to be understood, that we should not be scanning this patient. And, for anyone with a high prolactin, doing a baseline TSH is very, very important.
Yeah. Pituitary pseudotumors can be missed out and might be thought about like a non-functioning or any other pituitary macroedema and probably been referred for the surgery. Yes, sir.
Sorry, am I allowed?
Yes, sir, please.
In addition to the other, one more academic point is since reproduction is discussed, PCOS kind of situation can get aggravated both by hypothyroidism and by hyperprolactinemia, and that also, need to be, after treating all this, that may get unmasked from below.
Yes, sir, thank you for the added point. So the learning objectives is that when a patient with hypothyroidism comes, if they have a mildly raised prolactin or maybe a frank prolactin, it's important to look for hypothyroidism as part of the investigation. So that's what been evident in this particular patient, where we had overt hypothyroidism with mild hyperprolactinemia, wherein the patient has been planned for thyroxine therapy. So going on to the second case, this is a lady who came with history of galactorrhea and been married for the last 4 years, has irregular cycles, and this lady had no features to suggest hypothyroidism clinically. However, she had weight gain of around 6 kgs over the last 2 years. And on probing, she was taking domperidone for her abdomen pain over the last 1 year. So the clinical findings were suggestive of galactorrhea, and her investigation was suggesting a mild prolactinemia in the when was done prolactin dilution, and the TSH was normal. So I would like to ask Dr. Anand, what is the reason for the high prolactin levels?
The most common reason in this particular situation is going to be probably drug-induced. So if you look at the history, this particular person was on medications which included antiemetics. And as P.G. Sundararaman sir said, initially, we need to understand that how the prolactin is basically under the control of dopamine. So we have the arcuate nucleus in the hypothalamus, and then we have the connection from the hypothalamus to the pituitary through the dopamine, which basically exerts its effect through the D2 receptors. And that basically inhibits the prolactin. And with agents which actually act on this pathway, whether it is a pharmacological aspect or it's a kind of compression, this would alter this pathway. And specifically with some agent like domperidone, which basically is a D2 receptor and D2 receptor blocker, you basically would get an elevation of prolactin because of this. And generally with drug-induced hyperprolactinemias, we would expect ranges around 100. With some agents, like risperidone, you could even reach up to 200. So it is important to identify a drug-induced hyperprolactinemia.
Thank you, Dr. Anand. I'll just ask Dr. P.G. Sundararaman sir, so how do you address this problem? Because we know that quite a lot of drugs cause this problem of hyperprolactinemia.
Yeah, it's quite interesting that as Dr. Anand has highlighted that if you have a deficiency of the dopamine in form of secretion or in the form of metabolism or in the form of receptivity, then definitely the prolactin will be elevated. So they have listed down the causes of the medications that will cause hyperprolactinemia. One is that to understand it, we can stop the drug for about 2 weeks, then the prolactin decreases if it is going to be a drug-induced one. So that is one form. Or if it is due to a drug-induced, we can change the medication. For example, antipsychotics, lesser psychotic medications like risperidone can cause an increase of prolactin elevation. Then that can be substituted by ariprazole or olanzapine or quetiapine, like these drugs, which does not have much effect on this dopamine axis. Third is that we can reduce the dose of the medication and see whether this dose of medication reduction cause a decrease in the levels of prolactin. The third possibility, where you cannot avoid that medication, you can add on a dopamine agonist. But the problem with the dopamine agonist addition is sometimes can precipitate the original symptoms. So we must get in confidence with the psychiatrist that the patient is already on antipsychotics to know whether if you add on this medication, it will exaggerate the clinical symptoms. So these are some of the possibilities that we can think of when you know that it is going to be a drug-induced one. Another interesting one, some of the cases I've seen that as soon as they find a high prolactin, they do an MRI scan. And sometimes you find a small incidentalomas. Then they think that it is due to the tumor, they start treating it. So that must never be as a reason for starting the dopamine agonist. You must stop the drug for 2 weeks and see whether it is a drug-induced or not.
It's very important to get the clinical history first before going for the next step of investigation, because if a patient is having history of psychosis in the past or schizophrenia, the risperidone can increase the prolactin multifold and even more than 500 nanogram per deciliter for your lab also. So it's very important that before going for the investigation such that of an MRI, it's important to go for the good clinical history, because it's very, very important to have that.
Just to add on, many times patients don't reveal the history of antipsychotics and antidepressants. They may come out with the PPA use. So maybe repeated questioning may bring out that they are on drugs, and that will help us to help.
Yeah, exactly, because many times patients say that I'm taking pantoprazole, but when you ask them to bring the prescription slips, it says pantoprazole, and the patient may be taking pantoprazole plus domperidone combination for many years unknowingly. So that's actually, it's a very, very important clue. We just need to probe in to get the history in detail.
Another interesting phenomena is that if you find the prolactin is more than 250 to 300, it is likely. If you find something less than that, then you must think of secondary causes. That's very important.
Dr. Sandil, would you like to add up some more on the solution for this particular problem?
Yes, sir. Along with for dyspepsia, this domperidone, levosulfurate is also commonly prescribed. So most of the time when we are asking, patients will be taking either pantoprazole with domperidone combination or pantoprazole with levosulfurate. So we should avoid domperidone and levosulfurate to extent possible, and at the same time, if patient is taking antipsychotic medications, we should have a discussion with the psychiatrist. The antipsychotic medications which can cause least elevation of prolactin levels, like aripiprazole, qutipin, these also can cause mild elevation, but not to extent of risperidone like that. So we should have a discussion with the psychiatrist also. So we should avoid commonly this nowadays, like multivitamin and calcium, this domperidone and levosulfurate is commonly prescribed. So we should avoid these medications.
Yes, sir. Please add on, sir.
List is alternative medicines. We have seen quite a few occasions. We have reported also, like Pankaja Kasturi. Recently, I think my PG is here. We had a patient where this green tea was taken specifically, this Lipton green tea was containing something, and after stopping it, it is coming down. So there are many things which, you have to probe. And prolactin, very sensitive hormone, I think. It is affected by many things, and some of the herbal and other products, we don't know what they contain. Yeah. So best to stop everything and reassess.
Yeah. Any kasayam, maybe we don't know the content, might be a cause for prolactin elevation in any of our patients. So it boils down to the point that history is the foremost important for a patient before going for the next investigation if they have a high prolactin levels. So I just summarize that the first and foremost thing in patient if they come with a galactoria is history. Go for a detailed history, probably back and forth in their old reports is very important, because many times patients tend to forget or mask their past history that they might be going for antipsychotic therapies, or they may be unknowingly taking a medication which has an added levosulfurate or domperidone. And it's important to liaise with a physician or a psychiatrist to make sure that medication is changed, because particularly in this patient is having primary infertility and probably multifactorial, but this hyperprolactinemia also could be a cause for the problem. So going on to the next patient, this is a 24 lady married for the last 1 year and on primary infertility therapy. She was gained weight but no hypothyroid symptom, and she had galactoria. So the investigation showed that the physician mentioned that to do a prolactin, and it came as 34 nanogram. For that particular lab, it's slightly high. So I would like to ask Dr. PGS, sir, that so what are the other reasons for high prolactin levels other than whatever we have mentioned?
Yeah. The prolactin elevation can be of physiological or it's going to be pathological. Now, there is also physiological elevation like pregnancy, lactation, stress, and those are basically physiological. Even wearing a tight garment over the chest, that has been one of the inciting causes for elevation of prolactin, or a repeated nipple stimulation or sexual intercourse. All this can increase the physiological elevation of prolactin. Apart from that, the pathological are, it can be due to a prolactin secreting adenoma, or it can be any other lesion in the hypothalamo-pituitary region which is causing stalk compression, or the entry of dopamine is going to be curtailed. Then apart from that, we must think also of renal failure and hepatic failure. Many times, chronic kidney disease, there can be an elevation of prolactin. So that must be taken into account. And sometimes you find an analytical problem with, in the case of a macroprolactinemia. So these are things that must be kept in mind. So whenever you see a galacturia, and you must think of the physiological, rule out physiological causes, then go for a pathological causes. And in case when there is a very mild elevation, you must also think of a polycystic ovarian disease. That's also into, that is the, so one of the important issues that is cause a elevation of prolactin.
Thank you, sir. Dr. Anand, would you like to elaborate much more on this particular problem? Because we had here the prolactin of 34, and the patient is having a galacturia. There is kind of a slight discordance there here, and so can you please elaborate on this?
Yeah, as PJ sir said, I think it is important to understand whether this is physiological or pathological. Now here we have a patient with a high clinical pretest probability. So you have a patient who has galacturia and who is actually presenting with basically a prolactin which is borderline high. So we are very dependent on the laboratory to kind of assess whether this is a true rise or this is just a false rise. So it is important to understand that prolactin is measured through immunoassays. And immunoassays, can be, fooled. So immunoassay is dependent on antigen-antibody complex formations. So you have a particular antigen, which obviously in this case is going to be prolactin, and you have something called the capture antibody and the detection antibody. And you would expect that these actually sandwich, and then it will show up as a luminescence. So here, if suppose, just in case, you have a very large amount of prolactin circulating in the system, if you basically saturate the capturing and also the detecting antibody, you will get a low readout, which actually is a laboratory analytical error. And this is called the high dose hook effect. So to eliminate this, nowadays, we have better assays, so that is important. The other important thing is to understand is to eliminate this, you have to basically, dilute the sample. The dilution is important. The recommendation is dilution of at least 1 in 100 is very important, because 1 in 50 sometimes is not enough. And you have to dilute it to 1 in 100. And if you dilute it, it may show up as a very high level, and it may actually prove to be, a good point to diagnose. So this is an important thing to consider. So the laboratory is key in making the diagnosis. And also when you take the sample, if it's repeated venipunctures, as Sir mentioned, sometimes physiological causes, that could also basically, cause a rise. So that needs to be, looked at. But normally, if it's a good laboratory, it should be good.
The only thing that I want to add is that it must be taken in a fasting state. The prolactin sampling must be taken in a fasting state, And it is always better, even though it has got a long shelf life, you must take a pooled sample also, or repeat the prolactin again. As Dr. Anand has highlighted, that whenever you have a doubt, you must repeat or you must talk with the laboratory. What is the problem? Then we can sort out the differences.
So yeah, it's very important that when you order a prolactin in any lab, it's important to do it in dilution, because high dose hook effect can predominantly affect lab estimation, as already been discussed. So if you don't mention it, the lab is likely to miss it, and there is likely that we might, our diagnosis might be delayed also. Dr. Senthil, what are the pituitary specific causes for high prolactin? Because we know that this lady has prolactin in dilution of 300 nanogram.
Yeah, the most common cause is prolactin secreting pituitary microadenoma, followed by pituitary macroadenoma. Sometimes this GH secreting pituitary adenoma can co-secrete prolactin. Non-functioning pituitary adenoma also can cause, because of the stalk effect, it can cause mild elevation of prolactin. So these are the pituitary causes. Apart from adenomas, hypophysitis, lymphocytic hypophysitis can also cause elevation of prolactin. Sometimes patient will present with galacturia as initial manifestation, and supracellular mass like Rathke's cleft cyst, craniopharyngioma. So any supracellular mass by compression stalk effect, it can cause elevation of prolactin level.
Yeah. PG sir, can you just elaborate on the signs and symptoms of prolactinoma?
Yeah, it's quite interesting that there was a study in Massachusetts Children's Hospital. In fact, I thought prolactin elevation is unlikely in children, and that can be due to kidney failure or hypothyroidism, those or a tumor situation. Normally, the symptoms start from the adolescent period. There I have seen people presenting with primary amenorrhea. Higher prolactin can cause the primary amenorrhea is one of the important reasons, or a polycystic ovarian disease, where it can cause acne or minimal hirsutism. And in cases where in adolescent population, they can have, after the menarche, menstrual irregularity, and also they can have amenorrheas. Many times they have amenorrhea, and in the reproductive period, they have higher chance of infertility and ovulation. It's quite interesting that sometimes even a minimal elevation of prolactin can suppress the GnRH rhythm, and that can cause anovulation and it lead on to infertility. And in cases where if the hyperprolactinemia is present, it can also lead to bone changes, and it has been shown that it can cause osteopenia and osteoporosis. Now, whether this has an affection on the males, yes, definitely they have erectile dysfunction. They also have the changes in the semen quality, and sometimes very elevated prolactin levels sometimes can cause galacturia even in males, and it can also result in the reduction in the size of the testes also. So these are some of the finer points. So whenever a male is complaining of erectile dysfunction, then definitely you must look out for prolactin. And what are the signs, symptoms I told you for women? Definitely you must go into and probe and do a prolactin estimation.
So, Dr. Adeline, this is the MRI was done for this patient, and would you like to add a few points on this particular patient where he has microadenoma?
This MRI shows an hypodense lesion on the left side of the pituitary gland, suggestive of pituitary adenoma, and in this case, possibly a prolactinoma. And on the right hand, we can see the contrast uptake of the adenoma. Usually, what we need to understand is, just to add a point on the hook effect also. So usually, the prolactin will be not very normal. So you have an hook effect. You tend to what I'm trying to say is the prolactin will not be normal. The prolactin will be high, but not as high as what you would expect in terms of a macroprolactinoma or a microprolactinoma. Instead of being in thousands, it would rather be around 100 or 80 or so. So that way, you will never miss a prolactinoma. But many times when you have an MRI showing a pituitary lesion like this, and when you see the prolactin levels not as high as you would expect, probably a dilution is mandatory. Now, prolactinoma is the most common functioning pituitary adenoma, and we have very good agents, the dopamine agonists, as has been discussed. And what we predominantly use is cabergoline, and they do respond very well, unless for rare occasions. So we generally start with 0.25 milligrams or 0.5 milligrams more commonly once a week, and we often follow them up with repeat prolactin levels, maybe at the end of 2 to 4 weeks. And then the cabergoline, mainly what it does is not just reducing the prolactin level, but also offers a shrinkage of the tumor. So that is the only medical management that is possible for any pituitary lesion for that matter.
Yeah, thank you, Adeline. And we know that cabergoline is the therapy for this problem and not the surgery, because this particular lady is planning for pregnancy. Would you like to give any specific instructions in this patient when they plan for the pregnancy? Because the primary problem is infertility in this patient. So
I think one such rewarding thing is when you treat prolactinoma very well, the chances of spontaneous conception is very high. So we have had patients who on cabergoline therapy do conceive. Many times we'll be wondering why the prolactin is normal, patients are still having amenorrhea. It might be pregnancy. We have had instances like that. So one of the rewarding causes of prolactinoma, of treating hyperprolactinemia, is to have a prolactinoma with infertility. The moment you initiate them on cabergoline, they do respond well, and spontaneous conceptions also happen.
Yeah. Dr. PG, sir, can you just elaborate that this lady is, consider that she is pregnant now. What about the cabergoline subsequently? Shall we continue? How do we take it further from there?
Yeah, there are studies of the tumor growth during pregnancy. In fact, for microadenoma, it's around 3 to 4%. And for macroadenomas, it can be about more than really about 30%. So microadenoma, the increase in size is not very great. And in fact, when you have a definite shrinkage of the tumor and the normalization of prolactin before the pregnancy, it's definitely we can stop the cabergoline. You know that the two important medications available in the market, one is the bromocriptine and cabergoline. The bromocriptine must be given daily because of the short half-life. Cabergoline is given about 2 times a week or maximum 3 times a week. The maximum dose of bromocriptine is 15, and for cabergoline is 3. So whenever they enter the pregnancy, it's better to stop it. Now, there are conditions where you cannot assay a prolactin level during pregnancy because it tends to be increased, because pregnancy is a physiological cause for elevation of prolactin. So we cannot assay a prolactin. The only thing that we can assess by the visual field or very rarely by an MRI scan. So I think as we proceed with the discussion, we'll be having more discussion on it.
Other panelists, would you like to add any on how to follow up this patient subsequently in the next trimester and postpartum? Would you like to add up?
See, I think pregnancy is a very important and interesting aspect. I think the question basically addresses 2 things. What does pregnancy do to the pituitary, and what does the drug do during pregnancy? I think these are the 2 things which needs to be addressed. Now, if you look at pregnancy per se, leave alone, a person with prolactinoma, you take someone, a normal person, you would expect that the pituitary increases in size gradually with each trimester. And even postpartum, the first week or so, the rise is very big. And this is contributed with 2 things. One, because the pituitary is very vascular, so you're going to get an increased blood flow. And also the estrogenic effect of the pregnancy is going to stimulate the lactotroph, so this is going to happen. And this is what Pijay was saying, that along with this, the adenoma rise can also be there. Generally, it is purported to be not very high. And if someone is pre-treated well, This is not there. So the principle is, if you pre-treat and you plan the pregnancy, you can stop the dopamine agonist therapy at the point of when you know that they have conceived. Now, looking at drug trials, so cabergoline and bromocriptine in pregnancy, the widely studied drug is actually bromocriptine. You've got at least 6,000 odd patients studied, and they've been followed up, even infants, children have been followed up close to 9 to 10 years, and people have done well. So with pregnancy, the maximum data is with bromocriptine. However, as mentioned, cabergoline is more specific. It is very important in terms of its very rapid resolution in terms of the tumor size, prolactin normalization, symptoms, and also fertility. So that is why we prefer cabergoline. And in terms of cabergoline, again, this has been studied, although not to that numbers in terms of pregnancy, but again, we would do the same. With microprolactinoma, yes, it needs to be stopped. Macroprolactinoma pre-treated too, it needs to be stopped. However, if you have someone with progressive compressive symptoms, you may consider therapy with careful clinical monitoring and also visual field assessments based on how they are doing during pregnancy. So it is a very fluid area depending on what the patient is having.
Yeah, few more points to add. We should educate the patients in case of macroprolactinoma. In case of any diminished vision, they should consult the endocrinologist or physician immediately. So proper visual field, in case of macroprolactinoma, at least once in 1 or 2 months, visual field examination is mandatory. If the visual field examination, if there is any decline in visual acuity, then only imaging is indicated. Unnecessarily, MRI is not advised in pregnancy. So close follow-up clinically and with visual field examinations.
Suppose this same lady has a macroprolactinoma of this particular dimensions in this MRI. How do you approach this patient? Can you please elaborate on this? Because when we look at an MRI like this, and the patient tend to say that, how can you start with medication? Probably I need a surgery and come for an opinion. Arlene, would you like to elaborate on that?
I think with such a macroprolactinoma, I'm not sure whether patients can have spontaneous pregnancy pre-treatment. So, as I said, the prolactinomas generally respond very well to dopamine agonist therapy. So, even for a macroprolactinoma, the therapeutic option is only dopamine agonist, unless you have a significant visual field effects, which is very, very rare and which very rarely needs a surgical approach. So, even in patients who have macroprolactinoma with visual field effects, we still go ahead and give dopamine agonist therapy. The precautions that we need to take is that whenever you have a macroprolactinoma that responds very well to cabergoline therapy, the risk of CSF leak is common because of the erosion of the cellular floor. So therefore, whenever we treat macroprolactinoma, we are very careful and instruct the patient that patient may have a CSF leak. So we start them on a low dose and probably follow them up more closely than we would for a microprolactinoma.
No, it's quite interesting that any elevation of prolactin will cause anovulation, and they will have more incidence of infertility. So conceiving is a problem. So at that point of juncture itself, one must evaluate the patient. So it is actually, these type of macroadenomas must be managed before the pregnancy itself. So if it is not subsiding with the medication, surgery is very important. So where you remove the adenoma, so that the probability of its going to be increasing is less. It is around 5%. So it is better these patients, when they come to us with infertility issues, then we are investigating, finding a high prolactin, or by doing an MRI scan, you have a macroadenoma. You must definitely pre-treat them with surgery if they are not subsiding with the adequate suppression with the medication. Definitely you must proceed with the surgery and do this. In case if they become pregnant with a macroadenoma, the possible methods are only by visual field examination, and if required, MRI scan. So these are all subject to the patient evaluation. They have shown that people with the tumor abetting near the optic chiasm are a major risk factor. So they are supposed to increase in size much, and that may cause various other defects on the pathology. And they have shown that multiple studies have been shown that bromocriptine, lot of studies are there where it has been used during pregnancy. Even though cabergoline, they have done recent studies, they have not shown any pregnancy loss or preterm birth in these subjects. So it is also being used. But once again, it is very important and pertinent that whenever a patient comes with anovulation infertility, we must investigate for prolactin levels and do the proper treatment before the pregnancy. So counsel them. So before the pregnancy itself, they get treated properly, then you allow the pregnancy to occur. And even in very rare cases when there's a macroadenoma, they do a surgery in the second trimester, but the morbidity and mortality is very high.
So, yeah, as PJ sir said, I think it is very important that, pre-pregnancy counseling is, is given for these patients, and they have to have the pregnancy planning accordingly. So, we have wonderful drugs to actually, normalize prolactin, actually reduce the size. So, we should ask them to be patient and wait for normalization of prolactin and at least a 50% reduction in huge macroprolactinomas as in this case, because, during pregnancy it otherwise would be a nightmare. If obviously they are in a hurry, then you could offer transfemoral surgery, but with the caveat again that they could have hypopituitarism, which obviously would impair their fertility. So that is another issue. Another important aspect during pregnancy is someone who's, a macroprolactinoma, even a microprolactinoma, rarely this occurs. Someone who's stable suddenly gets symptomatic, very severe headaches, splitting headaches, that is an alarm bell. So we need to sometimes warn our patients, say, if you're going to get these symptoms, you need to report to us immediately, because you could have a pituitary apoplexy, which could happen during pregnancy. And during the therapies, as Dr. Adeline mentioned, if there is, a leak down the nose, that is important, because people will not understand what a CSF leak is. So we say that, you have something like, a nasal drip, which basically doesn't sound like a cold, or, if you have a nasal drip which is on one side, that is something which you need to report. These are practical aspects which we need to tell our patients.
Yeah.
Another interesting point that I've noticed is some of these patients, especially coming from morning sickness, they consume the prokinetic drugs. So that must also be kept in mind, because the prokinetic drugs can increase the prolactin levels. So that must also, even though it's a very minor issue, one must keep in mind that adding this prokinetic or antiemetics can elevate the prolactin levels.
Yeah, it's very important that education is a foremost, because educating our patient, especially when they, we have discussed a couple of patients, micro and macro prolactinoma. It's important to educate them that come for a yearly physician intervention or treating doctor's intervention, because many times they do not know about the CSF leak or an apoplexy symptoms. Because it's very easy to teach them, because if the patient bend forward or a unilateral nostril having a leakage, or a simple test is where they put their kerchief and take that, it does not stick like a mucus. So it's called kerchief test. So you can have a simple educating your patient to come for an early follow-up if they have a macroprolactinemia on treatment and conceived. Because many times this particular drug, cabergoline, we have seen in patients where when we give cabergoline in the morning, they tend to have some giddiness because of the postural hypotension, which is common in Parkinsonism. So this is one of the drugs which was given for Parkinson, anti-Parkinson treatment. So giving the cabergoline towards evening actually nullify this effect of mild postural hypotension also. So, so you mentioned, yes, sir, you want to add up one?
No, another important point, just even though this dosage does not cause cardiac changes, because in higher doses of the bromocriptine, they have shown cardiac valvular or defects or fibrosis, but this is uncommon. The only thing that I want to add is, it's quite interesting that the postpartum remission of microadenoma is very high. Sometimes they can have a complete remission after the pregnancy with a microadenoma.
Yeah. So I would like to summarize here that mild prolactin elevation could be because of multiple reasons. One is hypothyroidism is a common denominator for that. Secondly, drugs is a very, very important cause for prolactin elevation, and as we discussed that there are products which is called as Pativaithyam and Kashayam, all may be having could be a stimulant for that or an inhibition for the inhibitory pathway which is suppressing the prolactin. So it's very important to get a good clinical history to probably even stop whatever the medication, unknown medication. And thirdly, this patient, they have a micro or macroprolactinoma. Generally, they are not fully an infertile because it's because of the prolactin elevation causing ovarian dysfunction. So treating them with cabergoline make them having a normal menstrual cycle and subsequently can have a normal fertility period also. And especially in macroprolactinoma, it's important that we need to aware that these patients, when we start on cabergoline, the tumor shrinks, and once they become pregnant, there is a chance for increase in the size of the tumor because of the normal physiological change. So those patients, we need to keep them on close follow-up, especially with frequent visual field assessment, because that simple visual field assessment will give a clue that whether the patient has an if there is already an pre-existing field defect, that you can look for an worsening of field defect, and subsequently a MRI may be indicated if required and treat accordingly. So thank you panelists for the wonderful discussion here, and I move across audience for any questions, queries or clarification if you want to put forward. Thank you for the patient listening.
Any questions from the audience? So I think, thanks so much.
Only thing that whether we can stop bromocriptine or cabergoline in a microadenoma where there's a complete remission, with a minimal dose after 2 years, definitely there are chances of stopping the medication and reassessing the patient. So it is not like that in a microadenoma they must be taking the bromocriptine or cabergoline for lifelong. We can definitely reassess these patients, and henceforth, so that we can also stop the medicine, and if the minimal dose that is for 2 years, then we can definitely stop the medication.
Thank you, sir, for the
Thanks, Dr. Felix and the panelists for excellent discussion. May I request Dr. Sriram sir to come on dais to give the mementos and certificates to Dr. Felix and the panelists. Dr. P.G. Sundaraman sir. Dr. Felix. Dr. Adeline. Dr. Anand Kumar. And Dr. Sendil Raja. So moving on. So thanks so much, Felix and the panelists for the excellent presentation and discussion. Moving on to the next symposia. So can I ask the chairpersons to come on stage, Dr. Jyoti, madam, and Dr. Kalpana, madam.
So sorry, so Can I request Dr. Jyoti and Dr. Anandi, professors of obstetrics and gynecology, to chair the session?